Om Swastiastu, hello doctor and friends. We are from SGD 8 and we would like to present our student project about fecal incontinence in pregnancy. Okay, thank you for the time. My name is Nyoman. This is Adjani with last three digits of number 011 and I'm going to explain the background of this student project. Next slide, please. Fecal incontinence in pregnancy is a condition of involuntary loss of feces during pregnancy. It's very common in the third trimester, with pregnancy and delivery are the two major risk factors. Fecal incontinence it causes suffering and becomes a health burden. It's a very rare condition with an estimated prevalence of up to 4%. Another study of pregnant women in Saudi stated the prevalence of fecal incontinence, namely around 6.1%. This is associated with difficulty in determining the actual prevalence due to the risk of underreporting, including shames and stigma due to patients' non-physiological defecation functions. Therefore, its physical, social, emotional, and mental impact is devastating, affecting the patient's quality of life and in the worst scenario leading to depressions. On the other hand, fecal incontinence in pregnancy is a topic that is under investigated by the health professionals. This is due to the absence of typical clinical pattern and pathway to determine whether each pregnant woman is at risk of experiencing fecal incontinence. Due to this urgency in these matters, medical students are required to further study fecal incontinence in pregnancy. I think that's all from me. Thank you.
Swastiastu. My name is Bryan Tjandra with the last three digit 152, and I'm going to explain about 1.2, 1.3, and 1.4. So, the first one is problem formulation. There are six problem formulation. First, what is the definition and epidemiology of fecal incontinence in pregnancy? Second, what is the pathophysiology of fecal incontinence in pregnancy? Third, what are the clinical manifestation of fecal incontinence in pregnancy? Fourth, what is the diagnosis? Fifth, what is the treatment? And sixth, what is the prognosis of fetal incontinence in pregnancy? The objective, there are six objectives, is to know the definition and epidemiology, to know the pathophysiology, to know the clinical manifestation, to know the diagnosis, to know the treatment, and lastly, to know the prognosis all of the fetal incontinence in pregnancy. Benefit, there are two benefit. First is theoretical benefit to obtain information and provide a new understanding about fecal incontinence in pregnancy, and to obtain references for further research. For practical benefit, it's to enhance medical skills, including management and education for patients through the theory acquired in this study. That's all from me. Thank you.
My name is Adjani Sayidina Pakpahan with student number 031 and I would like to explain about the definition and epidemiology. Fecal incontinence is defined as the involuntary passage of feces via the anus or the inability to regulate the outflow of stool contents. Its intensity varies from involuntary passage of flatus to complete fecal evacuation. Depending on the severity of the disease, it can significantly affect the patient's quality of life. Over 5% of women worldwide suffer from fecal incontinence, and compared to men, they are more likely to characterize their FI as moderate to severe. One of the most widely recognized risk factors for fecal incontinence is pregnancy. However, it is a far less common dysfunction during a pregnancy, with a prevalence of approximately 4% of women in the 12th week of pregnancy. Because of the social stigma associated with FI, patients may not report their symptoms to clinicians, and the condition's psychophysical, and social effects may go unnoticed. It can have a devastating impact on quality of life and may even last beyond childbirth. And I think that is all from me. Thank you.
My name is Udayana with three last digit of my student number is 074. I will explain about the pathophysiology of fecal incontinence in pregnancy. Fecal incontinence or FI in pregnancy is primarily caused by the hormonal changes that occur during pregnancy, which can weaken the pelvic floor muscles. The increased pressure on the pelvic floor due to the growing uterus and the baby's weight can also contribute to FI. FI in pregnancy is a complex condition that can be influenced by various factors including hormonal changes, weight gain, and stool consistency. Further research is needed to better understand the pathophysiology of FI in pregnancy and postpartum and to develop effective prevention and treatment strategies.
Hello, my name is Nikita Devi Prastiti with last three digits student number 028, and I would like to explain about the clinical manifestation. So there are two kinds of incontinence in the bowels. First one is Earth's incontinence, which is the need to defecate urgently but are unable to go to the bathroom quickly enough, causing leakage of stool or gas that can't be controlled. The most prevalent kind is this one, and usually in pregnant women, the pelvic floor muscle weakens and disrupts bowel movements. The second one is passive incontinence, which is a decreasing awareness of the need to have a bowel movement or pass gas, even when the rectum, which holds waste, has stretched to the maximum extent possible to keep the leakage or gas. This kind in pregnant women typically entails problem with the pudendal nerves. The symptoms could happen more in pregnant women who have previous obstructive anal sphincter injury and who are overweight or obese. That's all from me. Thank you.
My name is Rosevelani with the last three digit of ID number is 094. The diagnosis of fecal incontinence is obtained from history taking and physical examination. Essential history that can be asked to the patient include obstetric history like number of delivers, use of forceps, perineal tears, history of dystocia, and then characteristic of incontinence like fecal consistency and existence of gas, and then onset, timing, and duration, and then effects on quality of life, and then fecal incontinence with or without constipation, and constipation or diarrhea medication, and then medical history like neurological disease. Physical examination that can be performed include inspection. Inspection can examine for hemorrhoids, the presence of scars, skin excoriation, fecal matters, etc. Anal wing reflex, stroking perianal skin by cotton bud. Positive is if brisk contraction of external anal sphincter presence. If the reflex is intact, the pelvic nerve is paired with pregnancy and delivery. Rectal or vaginal touch. Examinal, vaginal, rectal muscle, tone, and sphincter defect. Ask patient to squeeze and tighten rectal or vaginal. If dovetail sign absent of anterior perianal folds in rectal touch positive, it indicates defect in external anal sphincter. That's all from me. Thank you.
Thank you for the opportunity given. Let me introduce myself. My name is Indra Simorangkir with the last digit of my student ID 098. I'd like to continue the explanation about diagnosis. During the physical examination, physician may examine the anus and surrounding area for damage, hemorrhoids, and infections. A detailed rectal examination may be necessary, and during this procedure, physician inserts a sterile glove into the anus and up into the rectum to evaluate the strength of the sphincter muscles. A stool sample also may be collected and analyzed to rule out infectious causes of diarrhea or other gastrointestinal disorders that could contribute to fecal incontinence. Depending on the findings of the initial evaluation, further tests may be ordered. This can include anorectal manometry to assess the function of the anal sphincter and rectum, and the anal ultrasound to evaluate the anatomy of the anal sphincter complex, or imaging studies such as MRI or defecography to assess the pelvic floor dynamics during defecation. Physicians will also consider to examine the physiological changes that occur during pregnancy, such as hormonal fluctuations, increase intra-abdominal pressure, and changes in bowel habits, which can exacerbate or contribute to fecal incontinence. That's all from me. The next slide will be presented by my colleague. Thank you.
My name is Putu Krishna Arsawardani Putri with last 3-digit number 027, and I will explain about the treatment for fecal incontinence in pregnancy. Management for fecal incontinence in pregnancy is classified into surgical and non-surgical. Generally, treatment should start with conservative management, including dietary modification and bulking agents. Dietary modification involves increasing fiber intake by increasing consumption of fruits, vegetables, whole grain, as well as reduced intake of fat, dairy products, and processed carbohydrates. Fiber supplement may also be beneficial. Medications such as loperamide, atropine sulfate, and difenoxylate hydrochloride may aid in preventing fecal incontinence associated with loose bowel movement and diarrhea. Other options of non-surgical treatment may include pelvic floor muscle training and biofeedback. Pelvic floor rehabilitation increases the strength, tone, endurance, and coordination of the pelvic floor anal sphincter muscles, and resulting in positive functional change and symptoms reduction. Biofeedback therapy or BFT is recommended for patients who are unresponsive to conservative treatment modalities. In BFT, patients exercise control of external anal sphincter contraction and pelvic floor muscle with instant visual feedback from electromyography.
Hello, my name is Gusti Agung Ayu, Adinda Putri, with my last digit of student number R232. So today I'm going to explain about the surgical treatment in fecal incontinence in pregnancy. So there are a few surgical alternatives available to women who have not responded well to non-surgical therapy for postpartum fecal incontinence. Anal sphincteroplasty has been the primary surgical method used to treat postpartum fecal incontinence due to a sphincter defect. Sphincteroplasty is a procedure that restores sphincter integrity by repairing a damaged or weakened anal sphincter muscle to improve bowel movement control. And number two, the other surgical alternative for fecal incontinence is sacral neuromodulation. So, sacral neuromodulation is considered to modulate rectal sensation by activating or deactivating chemical mediating receptors, stimulating the efferent pathway, and altering brain activity associated with the continence mechanism. And the last one, another alternative for fecal incontinence is anal inserts, which temporarily occlude the anal canal and prevent stool leakage, are an option for pregnant patients with fecal incontinence. Renew inserts are a single-use, disposable silicone device that are effectuated at defecation. Well, I think that's all for me. Thank you.
Hello, my name is Joshua, and lesson number 205. Next, I'm going to talk about prognosis and complication. With conservative care, the majority of patients who develop fecal incontinence in the first year after delivery will observe a reduction in symptoms in the year that follows delivery. The first 3 months postpartum were the greatest for fecal incontinence prevalence, whereas the first 6 months postpartum were the highest for fecal urgency and incontinence. 7% of women reported symptoms for years after the first postpartum year, compared to 70% who experienced some fecal incontinence symptoms at that time. Patients should be advised nonetheless that this improvement could not last forever, because the prevalence of fecal incontinence rises with advancing age and the emergence of comorbidities that raise the risk of impaired neuromuscular function or stool consistency. Optimizing and maintaining anal continence requires keeping a well-formed stool consistency, making sure the rectum is emptied on a regular basis, and preserving pelvic floor and anorectal neuromuscular functions. For fecal incontinence patients may experience emotional distress and irritation. Being uncomfortable in public might result from losing control over one's body. Individuals who experience fecal incontinence may attempt to conceal the issue or steer clear of social situations. The anus surrounding skin is fragile and delicate, so stool contact on a regular basis may cause discomfort and irritation. Ulcers, commonly known as sores, may result from it. Medical care is frequently necessary for ulcers. Thank you.
Hello, my name is Indyarwan Ananta Seno with last three-digit name 091. The conclusion of our student projects are: fecal incontinence is defined as the involuntary passage of feces via the anus or the inability to regulate the outflow of stool content. Women are more likely to suffer from fecal incontinence, especially pregnant women. Pregnant-related FI or spontaneous fecal material leakage have a prevalence of approximately 4% of women in the 12th week of pregnancy. Fecal incontinence in pregnancy is primarily caused by the hormonal changes that can occur during pregnancy. It can weaken the pelvic floor muscles. Other than that, weight gain and stool consistency can influence FI in pregnancy. Clinical manifestation of fecal incontinence can be classified into urge incontinence, which defined as the need to defecate urgently but are unable to go to the bathroom quickly enough, and passive incontinence, which can be defined as decreasing awareness of the need to have a bowel movement or pass gas. Fecal incontinence can be diagnosed by history taking and physical examination to evaluate neurological disease and injury of the nerve. The physical examination that can be done are inspection, anal wing reflex, and rectal or vaginal toucher. Further tests such as anorectal manometry or MRI may be ordered. Treatment of fecal incontinence is divided into surgical and non-surgical. Treatment should start from conservative management such as dietary modification and bulking agent. Non-surgical management include pelvic floor rehabilitation that can increase the strength, tone, endurance, and coordination of the pelvic floor and anal sphincter muscles, resulting in positive functions change and symptoms reduction. Surgical alternatives include anal sphincteroplasty, sacral neuromodulation, anal insert, and etc. Patients who develop fecal incontinence in the first year after delivery will observe a reduction in symptoms in the year that followed the delivery by using only conservative care. Patients should be advised nonetheless that this improvement could not last forever, but the prevalence of fecal incontinence rises with advancing age and emergence of comorbidities that raise the risk of impaired neuromuscular function or stool consistency. Complementary that may happen to the patient are ulcers, skin irritation, and emotional distress. That is from me. The next part will be explained by my colleague.
Thank you for the opportunity. My name is Rosevelani with the last three digits of student number being 168, and now I'll be presenting about the advice of this student project. With the conclusion of this paper, there are several things that are suggested by the writers. More research should be done on the topic of fecal incontinence in pregnancy. As has been mentioned on the paper, fecal incontinence in pregnancy still doesn't have a clear typical clinical pattern and marker to determine the risk of it. This research is also very valuable for us the writers to understand about the topic better. We are able to pass on conclusion, thoughts, inquire about what comes about, critical and clinical data, and important sources of knowledge that we have done on our research this time. So that was the end of the presentation of our student project titled Fecal Incontinence in Pregnancy. Thank you so much for your time and attention.